Okay, good morning and good afternoon. Welcome back to our second day of South Asia and the Western Pacific Bi-Regional FETP COVID-19 online conference. So today we will have two oral presentation sessions. Right now, I would like to hand over to Dr. Tilaka to moderate our first oral session. Dr. Tilaka, please.
Thank you to the chairperson. Good day to everyone. Welcome you all once again for this Day 2 Southeast Asia Western Pacific Bi-Regional FETP COVID-19 online conference. We are in the first session of oral presentation now. I will be moderating this session and we have altogether 4 presentations where we are still waiting for one presenter to join us in. So before starting this session, I would like to remind all the participants or the audience of this conference to kindly mute your microphone if you are not speaking. And if you have questions, you can ask at the end of the session if you are in Google Meet site. Alternately, if you can also write your questions in the chat rooms of Google Meet or YouTube. Please don't forget to provide your name and your agency along with your questions when you are asking questions in the chat room. My final reminder to all the presenters, please keep your presentation within 10 minutes and another 10 minutes will be allocated for a Q&A session. We will make a sound like this. A sound will be produced at the 9th minute of your presentation, indicating that you have 1 minute left to conclude your presentation. Okay, I hope this clarifies the rules and instruction for this presentation. 10 minutes followed by 10 minutes question and answer. Okay, so with this, I would like to invite the first presenter for today's oral session, who is Ha Lin Kwek from MAE Program Australia, to share with us his presentation on in-flight transmission of SARS-CoV-2 during a long-haul flight, result from an outbreak investigation in Vietnam and implication for future air travel. I welcome you, Ha Lin.
Hi, thank you very much. Can I start now?
Go ahead.
Okay.
Go ahead.
So good afternoon and morning to all speakers and scholars of TEPINET. My name is Kwek Ha Lin. I'm from Australian National University and Vietnam National Institute of Hygiene and Epidemiology. And this is my presentation of in-flight transmission of SARS-CoV-2 during a long-haul flight. Next. So a little bit on the background, as we already know from past and current literature, air travel is contributing to the spread and extent of the pandemic, and COVID-19 is no exception. However, transmission risk from infected passenger to other crew member and passenger or in-flight transmission risk is still very limited in evidence. In early March, we detect a large cluster of COVID-19 cases among air traveling passenger on a flight from London to Vietnam. Next. So a little bit about the flight itself. The name is VN54. This is a direct flight from London to Hanoi on the early morning of 2nd of March. Lasts a total of about 10 hours. We had 16 crew members and 201 passengers on board, occupying business class, premium economy, and economy class respectively. Next. So we actually found the index case of the flight by her own presentation at the hospital. She actually, after a month-long living in London and traveling to Italy and France for Fashion Week with her sister, who also later confirmed positive for COVID-19, our index case actually fell ill on 29th of February, but continued to board the VN54 flight in the business class while being symptomatic. After coming to Hanoi, she self-isolated herself, but her symptom progressing until the 5th of March when she has to admit to the hospital and then confirm positive for COVID-19 on the very same day. So the investigation on her case actually start on the 6th of March. Next. So our objective is to analyze the probability that transmission of SARS-CoV-2 actually happened on the flight in question and to identify risk factors associated with it. So next. So whenever we have a case that we have flight travel history like this, we're going to work with Civil Aviation Administration and Immigration Bureau to get the flight manifest, handle it to National Steering Committee of COVID-19 Prevention and Control, who will monitor and transfer it to municipal CDC, police department, and local authorities at provincial level to contact, trace, test, and quarantine all possible passenger and crew member on board. So this applies for all passenger and crew member on the VN54 flight. Next. So for all trace passenger and crew member, with this very basic standard, we're going to check if they have symptoms at contact. We also do standard interview for close contact as well. And we also do contact tracing for this close contact. Next. So if they have symptomatic contact, we're going to isolate them. If they are not, we're going to quarantine them. They're all going to get SARS-CoV-2 testing right away. And if they are negative, they're going to be centralized quarantine for 14 days. Next. So in quarantine, we're going to monitor their symptom daily, and we also test them twice more, one on the 3rd day and once on the 13th day before they exiting the quarantine facility. Whenever they have symptoms, we're going to test them, and whenever they test positive, we're going to isolate them immediately. Next. So this is a result that we have. We found actually 100% of the crew members and 84% of passengers still remaining in Vietnam. So 33 passengers actually transit to other countries by the time of investigation. So we contacted them, tested them, and quarantined them, and we found 15 additional flight associated cases. So here's to remind that we have 16 cases in total on the VN54 flight. 50% being male, 75% being British, and among more than 1,300 close contacts that we all trace and quarantine, we found 5 additional community cases in Vietnam. Next. So this is the layout of the VN54 flight. After we done case interview, we can find that all the index case, the cell in the red, it actually set in the business class with a lot of cluster, a lot of other cases in orange cells surrounding her, making like the attack rate in the business class itself to 62%. We also found 2 other cases in the economic class, and one case is actually a attendance serving in economic class as well. So we can see the cluster very clear in the business class. Next. So seeing the risk ratio of getting SARS-CoV-2 infection in the business class was significantly 7.3 times higher if you are sitting 2 or less seats away from the index case, the symptomatic index case on board. Next. So this is a time course of all the case from index case number 1 to case number 16. We can see here that we found 4 case pairs that they actually travel and sat together on the flight, but none of the case pair or individual case actually go like they cross path or meet each other before, after the flight. So the only common exposure here is on the same flight as the index case. And we also found evidence of symptomatic, pre-symptomatic, and asymptomatic case on board. And we found, as you can see here, that we found only 3 people who actually symptomatic before we test and quarantine them. Next. So for the discussion we have that in-flight transmission hypothesis were really emphasized due to several reasons. In that case, was the only symptomatic person on board. She was with established contact to a confirmed case in her incubation period, which is her sister, who are also residing in London. For all the other flight associated cases, the incubation periods actually overlap with the flight time, which is the 2nd of March. And for community transmission in both England or Vietnam were not widely established at the time of the flight, so make it more unlikely that the case actually acquired infection from before or after the flight, other than like being on the same flight as the index case. So the possible routes of transmission, including aerosol or droplet transmission during the course of the flight, particularly in the business class with a symptomatic index case or contact outside of the aircraft at the airport before or after boarding, and reasoning why we saw another 2 cases in the economy class and 1 case in air attendant class. Next, so we have several limitations that we have. We don't have genomic sequencing data. We don't have environmental sample collected or detailed data of how the case actually activities on the fly. But however, we stand by our implication and results, which is next. We can conclude that long-haul flights can not only lead to the importation of COVID-19 cases, but also to super spreader events of COVID-19. So we recommended and actually implemented in Vietnam on the 21st of March, a systematic testing and quarantine policy for all inbound passengers upon arrival. We also saw in the cluster here that in-flight transmission was well beyond the 2 rows and 2 seat normal definition of close contact case on the airplane that we see very clustered in business class and also in other classes as well. So mask wearing, personal hygiene mandatory on board, health declaration and social distancing at the airport is very recommended and also implemented in Vietnam since 6th of March. Next. So this is an acknowledgement of all the people who have contributing to the study itself. And this study is also published on Emerging Infectious Disease Journal since early October. If anyone who interested can actually go find it in the same name or contact me afterward. Next. So thank you very much for the presentation. This is the end of my slide. So I hope to get a lot of good questions from everyone. Thank you.
Thank you, Harleen, for keeping up to your time. Congratulations, and that was a very good presentation. So we have few questions for you. There's question from Indonesia from Dr. Muhammad Asri. He said, any specific case definition have been used?
Yes, so actually, if you want to ask the case definition for the investigation itself, we actually use a very sensitive case definition at that time that we found all people, so all possible passenger flight on board a VN54 flight who actually have symptoms or don't have symptoms, we all trace them and quarantine them. But for the specific case definition of the study itself, suspected flight associated case gonna be passenger and crew member on the flight with symptomatic compatible to COVID-19, and confirmed flight associated case on the flight would be whoever a passenger or crew member on the flight who tested positive for COVID-19 by RT-PCR.
Thank you, Harleen. Any other question for Harleen? Please raise your hand. And also can use the WeChat, can use the chat box or the Google platform. Okay, Harleen, can I ask you a question? How was the case was picked up? Because we have seen there's a community transmission also involved in this investigation. So how the case was picked up?
You mean that how was the case actually implemented throughout the course?
How was the first case picked up? Because she was symptomatic and she took a flight and landed in Vietnam. So how did you pick up the first case?
Yeah, can I have slide number 4? So she actually presented herself at the hospital herself after being very bed rest. Like she stayed at home for 3 days, but the symptom continued to be worsen every day. So yeah, she actually went to the hospital herself, and then the hospital had a procedure that whenever a person showing up with like COVID-19 compatible symptoms, they're gonna test for COVID-19. and then she was test positive for COVID-19 at the hospital, and then her I think her test result also sent to National Institute of Hygiene and Epidemiology for confirmation, and then we confirm her positive the very same day. So that's how she present herself there.
Just to follow up with Halin, I can't see any questions in the chat box, so I'm just continuing. Following your investigation, is there any recommendation for any kind of surveillance at the point of entry?
Yes. Can I have the slide number? Let me see. Can I have slide number 14? So actually, in Vietnam, after we saw this particular case with cluster with this kind of magnitude, this is also the first flight that we done contact tracing for all passenger and crew member on the VN54 flight, and also on every flight that we have positive case of COVID-19. We actually implemented throughout the course until the end of March, because we also see a lot of importation of case. But then we also done a lot of like immigration point entry testing, like you said. So we done systematic testing and quarantine for selected country. So selected country by high risk. So we start with like only European countries on the I think 12th of March, and then we extended to USA and Russia and other Asian countries. And by the end, like by 21st of March, we quarantine and test everyone at immigration point upon arrival, just to mitigate the whole need and the whole burden for contact tracing in the country itself, and just to have everyone quarantined right away when they boarding to Vietnam.
Thank you, Halin. There is another question from Dr. Muhammad Asri too. Do you have any cross notification for country origin of flight?
I think actually cross notification, you mean that when we found someone positive in my country and then notifies to other country as well. So actually is that correct? I'm not sure if I understand it right.
Maybe you can answer both. Did you get any notification from
Yes.
the country of origin, or have you notified to other countries?
Yes, so actually on this flight and for all the flight forward, whenever we have a COVID-19 case confirmed in Vietnam, we contact all of the people on the flight itself. So anyone who actually transit to other country, we also notify the CDC in that country as well. So for example, on this VN54 flight, we actually found one person who actually transit to other country and then test positive there in Cambodia. So we actually work with Cambodia CDC to notify them. And this goes similar to all the other people who also send it to other countries with the flight itself coming to Vietnam with COVID-19 cases. But for vice versa, we also have people from like Japan. We have Vietnamese people coming to Japan or coming to to South Korea, and then they test positive there, and we also get notification coming back. And then we do reverse contact tracing back in our country as well.
Okay, thank you. I have another question from Dr. Bino Arai from Malaysia. How do you think was the mode of spread within the flight? Airborne droplets, or could it be through contact or vomit in the toilets?
Yes, so actually during the course of the flight, as I say, I think in slide number 12, that aerosol and droplet transmission is highly possible inside the business class, even though that people, except for people who know each other, they actually, the index state actually set in the very far right of the board. So aerosol and droplet transmission is very likely, but also sharing meals together and sharing the same toilet is also very high risk, because as you know, the business class have a very separate toilet with other class, so they share the same toilet together. So the vomit and sitting and talking to each other is also possible.
Okay, there's one more question from Philippines, Beans. If I recall correctly, there were 16 flights associated cases and 5 non-flight community cases. How could you be confident that they were associated with a flight case? and not community transmission from another source?
Yes, so the 5 non-fly community case we found because we interviewed all the fly associated cases, and we found out their list of close contact, and we contact trace them and quarantine them. And also for the close contact themselves, we also done standard interview for them and to find out if they have any exposure to other positive case or suspected case around them. So their connection to the only connection between the community case and between the fly associate case was that they found each other along the way. So there's only the only exposure that could be established, and with no other case around. So at that time, community transmission was not widely in Vietnam. We also have only 16 cases, and people were also very aware of the situation. So we very highly confident that the non-fly community case actually got infected from the fly case as well.
Thank you, Harleen, for answering patiently for all these questions. There is a lot more questions for you coming through the chat box and also other ways. So I think due to the time constraint, we have to go ahead with the next presenter. But please, Harleen, you are free to answer all the questions through the chat box. And also, if you have time, we will come back to the question at the end of the session. Okay? So please, thank you for your presentation. And now we will go to the second presenter. So if Mr. Surendra Mohan is in, Angela or the Secretariat, is he in? Yeah, I think I can see Dr. Surendra here.
Yes, ma'am. Good morning.
Yes, okay. Now we will go to the second presentation, which will be given by EIS Program India from Dr. Surendra Mohan Prachapati to give up his presentation on frontline response for the first coronavirus disease cluster in the largest state of India. So the time is yours, Dr. Surendra.
Sorry, can I just say, Dr. Surendra, could you, it seems like you may have more than one device that has a microphone that's on. Could you mute the other device, please? So we don't get the echo. Thank you. And then you can go ahead when you're ready.
Okay, thank you, ma'am. Good morning, everybody. Next. First cluster of COVID-19 cases identified in Agra district of the most populous state in India, Uttar Pradesh. We piloted COVID-19 surveillance containment plan of Government of India, described cases by time, place and person, and did contact tracing. Timely interventions prevented community transmission. Next. Last year, on 31st December, China alerted WHO about cases of pneumonia of unknown etiology. WHO notified India on 11th January. Thailand was the first country to report COVID-19 case outside China. India started airport surveillance on 18th January. Next. On 30th January, WHO declared public health emergency of international concern. India reported its first case. India's first indigenous cluster identified in North India on 2nd March, followed by declaration of pandemic on 11th March. Next. Agra is a city of Taj Mahal, one of the famous 7 wonders in North India. Population of Agra is 4.4 million with 45% urban occupancy. Team of EIS officers deployed to Agra on 4th March this year with the objectives of next. Piloting implementation of COVID-19 surveillance cluster containment plan and describing time, place, person distribution of cases. Next. EIS officers were deployed with effect from 4 to 28 March, and descriptive analysis was done for the period of between 4 to 26 March. Next. We implemented cluster containment strategy by setting up district control room, assessment of healthcare resources designated for COVID-19, and mapping of containment zones. Next. We assessed human resources and space for setting up district control room, and visited healthcare facilities for assessment of COVID-19 designated human resources and health infrastructure. We conducted meetings with district officials and planned for COVID-19 related trainings. Next, we mapped the containment zone around an epicenter. Containment zone was established around 3 km radius of epicenter for identification of cases and contacts and active surveillance for ILI cases for home quarantine. Surrounding 2 km radius was buffer zone, which enhanced ILI and SARI surveillance through the existing IDSP. Next, for epidemiological analysis, we obtained line listing of lab confirmed cases from IDSP Agra for time, place, person analysis. Next, we used standard case definitions of Government of India for suspect case, confirmed case, and high risk and low risk contacts. Next, district control room was set up with 514. Rapid response team identified 112 suspects and sampled 14 high risk contacts. Contact tracing team traced followed up around 1,000 case contacts. Area surveillance teams identified close to 3,600 ILI cases in the containment zones. Disinfection teams disinfected around 400 places, and call center team did 4,500 follow-up calls to quarantine cases and resolved more than 600 public queries. Next, Agra has 5 COVID-19 designated government healthcare facilities cumulatively. These facilities had 107 beds with 21 ICU beds with ventilators, 18 ambulances, and 60 doctors. Next, multiple trainings were given to 47 health professionals on surveillance, case definition and data flow, contact tracing, and infection prevention and control. Next, 3 containment zones were established. Containment zone 1 was identified around the cluster of 5 cases. Zone 2 was identified around the cluster of 2 cases. And zone 3 was identified around a single case. Next, close to 1,800 teams with 300 supervisors were deployed for ILI surveillance in containment zones. Teams surveyed more than 200,000 households and quarantined around 3,500 ILI cases for 14 days. As per Government of India testing strategy at that time, 4 ILI cases were sampled, none of which came positive. Next, contact tracing strategy included area surveillance and district control room activities. Out of total COVID-19 case contacts, there were more than 1,000 low-risk contacts and 14 high-risk contacts. RT-PCR was done for all 14 high-risk and 99 symptomatic low-risk contacts. 922 asymptomatic low-risk contacts and 108 RT-PCR negative contacts were home quarantine and followed up for 14 days. Their quarantine was considered complete once they were asymptomatic for 28 days. And those who were RT-PCR positive were admitted in isolation facilities and further contact tracing was done. Next, we also described cases by time, place, person. Next. As on 2nd March, we case 1 and 2 were COVID positive. There 3 out of 5 high-risk contacts turned positive on 5th March, depicted here as C3, C4 and C5. In the second containment zone, C6 was a low-risk contact of C1 and C2 and found positive on 8th March. C7 was high-risk contact of C6 and tested positive on the same day. In the third containment zone, C8, the high-risk contact of a case with foreign travel history, tested positive on 15th March. Average contact traced per case were 27, range 4 to 58. Next, median age of the 8 confirmed cases, including 5 males, was 38 years with a range of 16 to 70 years. 50% of the confirmed cases were between age group of 21 to 40 years. 3 cases had international travel history. Next, all 8 cases were hospitalized. Only one was symptomatic and one had comorbidity. No deaths were reported. Next, to conclude, we established 3 cluster containment zones and executed prompt responses by setting up of district control room, strengthening ILA surveillance, conducting trainings and contact tracing. Timely interventions with containment measures prevented community transmission. Next, based on the learnings from this response, Government of India replicated cluster containment strategy to other parts of the country, strengthened COVID-19 infrastructure by adding more isolation units, ventilatory support, and personal protective equipment. Next, these are my acknowledgements. Next, thank you very much.
Okay, thank you, Dr. Surendra, for this great presentation. And you have one question they ask you to give the case definition for high and low risk contact. What do you mean by high and low risk contact?
Actually, I have added in slide number 30, 31st. Can you see that?
The next slide.
The next slide. Yes. High risk contact lives in same household or touch patient's body fluid. Direct physical contact without PPE, touch the linens of the patient, cloth or disease, and even in close proximity within 3 feet. Passengers in close proximity within 3 feet for a conveyance with a symptomatic who later tested positive for 6 hours. In our study, high-risk contacts were living in same household.
Okay, Surendra, the other question is from Dr. Intan Azura from Malaysia. Using the cluster containment strategy, how long we can contain the cluster?
We started with cluster containment strategy on 4th March, and till 28th March there were only 8 cases. Till 15th March there was 8 cases, and till 28th March no new case was generated. So it was about 28 days. We contained the.
While we are waiting for others to type in their question, I have one question to you, Dr. Surendra. You had something called containment zone, which is about 3 kilometers, and also a buffer zone of 2 kilometers. Why do you let that 3 kilometers and 2 kilometers?
It was decided by district administration according to guidelines of National Center for Disease Control. It was allowed to district magistrate and district administration to decide the containment and buffer zone as per their convenience.
Okay, there is one question from Dr. Tarun. How was community transmission defined? How could you conclude that this containment prevented community transmission?
This containment prevented community transmission because no new second generation case was generated. It was restricted to first generation case.
Any other questions?
Hello, this is Jiaping Su from Taiwan. I have a question for you. Thanks for your presentation. So in your slide 11, you talk about the enhanced ILI surveillance. Could you please provide us a detail about how did you do that enhanced surveillance of IRI? Thank you.
Hello.
Well, I know about the enhanced IRI and SARI surveillance. Could you please talk more about this surveillance? Thank you.
I couldn't hear your question. Please repeat. Your voice was breaking.
Yeah, I'm sorry. So you mentioned that you did the enhanced IRI surveillance in buffer zone,
Yeah.
right? So could you please
Yeah.
talk more about that? How did you do the enhanced surveillance? Thank you.
Yeah. In containment zones, there were teams who were doing house-to-house activity, but in buffer zone, we enhanced our surveillance by National Integrated Disease Surveillance Program, which already existed in the buffer zone. So we picked up the severe acute respiratory illness cases, SARI cases, from the buffer zone.
I think there is the same question is raised by Mani Gandanesan. Was there any specific reason to choose 3 kilometers? I thought you have already answered that, something on the local council provision, right?
Yeah.
Does that depend on any density of the population?
Yeah.
We have few more minutes. Okay, I think since there's no more questions, I think I would like to thank Dr. Surendra Mohan for sharing your presentation. Thank you so much.
Thank you very much, ma'am. Thank you all.
Okay, now we will move to the third presenter, who is Deepasis Kumar Shaha from FETP Bangladesh. He will be presenting on zonal approach to contain the spread of COVID-19 infection in a district of Bangladesh. Dr. Deepasis Kumar, please. The floor is yours.
Yes. Can I start, ma'am?
Yes, please.
Yes. Good morning. I am Dr. Debashish Kumar Shah, Fellow of Field Epidemiology Training Program, Bangladesh. I am going to present the findings of the piloting of the zonal containment approach to contain COVID-19 infections in a rural district of Bangladesh. Next. Bangladesh is a country of Southeast Asia having 148,460 square kilometers and around 160 million population. The first case was reported on 8th March 2020 in Bangladesh. Government closed the school on 17th March 2020 and declared nationwide holidays and provide ban of domestic travel on 23rd March. Office and local transports are reopened 31st May 2020. Till November 2020, COVID-19 positive case has been reported over 3 lakhs and deaths over 6,000. Next. As countrywide lockdown is difficult to implement, the government of Bangladesh took initiative to lock down zones instead of whole country from 9 June 2020 to mitigate the COVID-19 spread. All sub-districts are divided into 3 red, yellow, and green zones based on diagnosed COVID-19 cases per 100,000 population in past 2 weeks. Next. In Bangladesh, most COVID-19 cases reported in urban areas or in cities. So definition of zones are different. In urban, more or equal 30 cases per 100,000 population are considered urban red zone, and 3 to 30 cases per 100,000 population are yellow, and less than 3 active cases are green zone. In rural, more or equal 10 cases per 100,000 population are considered rural red zone, 3 to 10 active cases per 100,000 population are yellow, and less than 3 cases was green zone. Next. The objectives of our study are to compare COVID-19 positive case incidence and test positivity rates before and after zonal lockdown, and to assess whether zonal lockdown can be used as alternative to country lockdown to contain COVID-19 spread. Next. We conducted the interventional study in the district of Bangladesh from May 29 to July 9, 2020. We gave intervention from June 12 to June 25, 2020. Next. We selected a red zone in Narshindi Sadar sub-district, one ward named Birampur. The area of Birampur is 1.25 square kilometer with over 30,000 population. Here you can see location of Birampur. We selected the area as red zone as it has the rate of active cases was 72 for 100,000 population. Next. For zonal containment, we gave temporary boundary surrounding the area and restricted movement. There were one entry and one exit point, which were guarded by police and volunteers. COVID-19 testing booths were set up in the piloting area, which was open 24 hours every day. Food and medicine are delivered by volunteers 24 hours every day. Ambulance was present 24 hours in red zone area for severe patient transportation. Banner and social visits for using surgical masks by the community people and also award for social distancing. Next. We defined confirmed COVID-19 case if any person tested positive for RT-PCR for COVID-19 at Birampur in Narshindi, Bangladesh from May 29 to July 9, 2020. We also defined active cases. Any confirmed COVID-19 case of Birampur in Narshindi from date of diagnosis to 14 days. Next. We calculated incidence of COVID-19 by the number of reported COVID-19 positive cases in week divided by the number of population as expressed per 100,000 population. We also defined positivity by the total number of positive cases divided by the total number of sample tested. Next. For comparison, we performed jet test for two proportions, COVID-19 incidence and positivity rate, before and during intervention. We set P less than 0.05 as level of significance. Next. This histogram showed that reported COVID-19 cases in Narshindi district was increasing 11th April up to 12th June 2020. Next. This epicurve shows active COVID-19 positive cases of Birampur from May 29 to July 9, where May 29 to June 11 indicates the before intervention period. From June 12 to June 25 indicate during intervention period, and June 25 to July 9, 2020 indicates post-intervention period. 2 weeks before intervention, a total of 23 cases reported. During intervention, 7 cases reported and no case was reported in the following 2 weeks of intervention. Next, please. Here we see the weekly rates of COVID-19 confirmed cases per 100,000 population. Although in the first week of intervention, the weekly reported increased, which might be due to increased awareness of people for testing due to declaring red zone. The overall COVID-19 rate significantly decreased during and post-intervention period than the before intervention period. Next. Third figure showed percentage of positive tests in Birampur, Narshindi, Bangladesh, May 29 to July 9, 2020. The percentage of positivity in the collected COVID-19 samples significantly decreased during and post-intervention period than the before intervention period. Next. We have limitation in the piloting. The study didn't include control area, and long-term follow-up analysis were not done to see how long the area was disease-free. Again, findings of only one area might not give the representative result. Next. In concluding, the suggest zonal containment approach that could be used to control COVID-19 transmission in rural sub-district of Bangladesh. Long-term follow-up is necessary before implementing it throughout the country. Next. We are recommending to implement zonal containment in multiple areas of the country and analyze the findings to see the effectiveness of the approach. We also recommend to conduct a qualitative study in the population of containment areas to find out the acceptance of the approach in the population. Next. I am acknowledging following offices and institutes of helping me to conduct the study. Institute of Epidemiology, Disease Control and Research, IDCR, Director General of Health Services, ATUI, and Field Epidemiology Training Program, Bangladesh, and other institutes of helping me to conduct the study. Next. Thank you.
Thank you, Dr. Debazis Kumar, for your great presentation. There is one question from Dr. Bina Rai. Since we know that this containment was being done a few months back, so now she's asking what is the status of COVID in the area now? Is this a sustainable way?
Sorry, you need to unmute
yourself.
Yeah.
Sorry. Thank you. As far as I know, now this area is decreased COVID-19 transmission than other areas of Narshindi district. Because this study few months ago.
Okay, so the next question is from Dr. Tarun. Is it correct to label the cases detected by week as incidents? Could some of them be prevalent cases?
Thank you. Because we done two comparison weeks, before intervention, during intervention, and post intervention. So maybe it see incidents, COVID-19 incidents.
Okay, one more question for you. Why zones were classified only based case per 100,000? Test positivity was not considered for deciding on lockdown, and the zone which tests less can have lesser cases.
Firstly, I say that it's a piloting approach. It's a zonal containment piloting approach in Bangladesh. And it is a sub-district of Bangladesh, and it is very close to capital city of Bangladesh. And capital city has international airports and many garments industries. So it totally depends on current data analysis and situation.
Thank you, Eldon. I've been missing your questions for a while. So this is a question from Eldon. How much resources were needed to maintain this containment?
We mainly local authorities like health authorities and administrative authorities helped us, and also many people, those are living in that area, that are the volunteers, they helped us also.
And one more question. Did those activities for containment also change over time?
Maybe it will be.
as the strategy being used for another place? There's an additional one more question.
We did this zonal containment another sub-district of Bangladesh. 4 to 6 sub-districts in Bangladesh is held.
So the outcome is the same, or is there any difference in the outcome from different states?
It depends. Not like this results. It depends, but close to this result.
While waiting for others to ask, I have one more question. Like, we have 3 zones, and you said there was a restriction of movement in the zones, right? So if
Yes.
a person staying in a red zone and working in a yellow or green zone, are they allowed to move and daily to go from the red zone to yellow or green zone?
No, it's totally restricted. The red zone people living in their house. We delivered food and medicine and others daily needs by volunteers to give their house.
So what about vice versa? People who are staying in green zone but working in red zone, are they allowed to go in and work in the red zone?
No, not at all.
It's a complete
totally different.
lockdown of the red zone.
Yes, totally different.
Any other questions from the audience? Someone typing. A question from Eric. Is it possible to cost what will be required to implement this in the other zonal area?
Could you repeat, please?
Is it possible to cost what will be required to implement this in other zonal areas?
Yes, it's possible. If any wants, it's possible.
And another question from Dr. Tarun too. How frequently did the zonal categorization change?
After 6 weeks, it will yellow zone. It will green zone, because we defined green zone less than 3 active cases, but we found no cases after 4 weeks intervention.
Okay, it's about 4 weeks. And there is one more question from Salim. How was the community engagement?
We inform there by miking and postering and awareness banner and etc.
So their cooperation was good?
Yes.
Or do you have any resistance from them?
Yes, they cooperated.
Are you following same? One more question from Sushil. Are you following same zonal approach in other areas now also?
No.
Why have you are you not following?
Because it's our country reopened 31st May, I previously said.
So you have released all the zones, so that means there's no more red zones.
No more red zones or other zones.
Yeah, so it's released. Okay, one more question from Eldon. What factors helped maintain the containment?
Mainly, they're strictly movement prohibited and COVID-19 testing regularly. Those have symptoms. And this is the most characteristics of containment.
You are very hot, Dr. Dibalis. Everyone is typing and asking you a lot of questions. So
no problem.
Okay, one more question. Was testing strategy and numbers same in all zones?
No, because we have case definition. Those have symptoms. We tested them.
Okay. Okay, I'm very sorry, Dr. Debazis, for bombarding you with questions one after the other. You did very well. Thank you for your time and for your participation in this sharing. Thank you so much.
Thank you.
Okay, we have come to the last presenter for this session, who's going to be Suganya Bharani from FETP Chennai, India. And she will be sharing with us today use of cycle threshold or CT values in predicting infectivity of the individual in transmission of COVID-19. I welcome you, Dr. Suganya. You can start, Dr. Suganya. We can't hear you. Are you muted? Angela, can you hear me?
Yes.
But I can't hear
Yes. Dr. Suganya, you need to unmute yourself. Can you speak right now? Go ahead. Thank you.
We still can't hear you.
Dr. Suganya, we can't hear from you. We can't hear you. Yeah.
No, we can't hear you yet. Maybe the same thing like we had yesterday.
Dia kena log in, log out balik dan log in balik.
No, I think can you log in and log out very fast and see?
Discussion, then 12:30.
Yes, am I audible now, ma'am?
Yes, we can hear you. Yes.
Please go ahead.
Good morning. I think that's the first glitch for the morning. I'm Dr. Suganya Bharani. I'm a recent FETP scholar with ICMR National Institute of Epidemiology, and I also work with the Department of Public Health and Preventive Medicine, Tamil Nadu. Our study was on the use of cycle threshold values in predicting infectivity of an individual in the transmission of COVID-19, which was done as a cross-sectional study in the month of August 2020. Next slide, please. There has been a lot of buzz around CT values and its role in predicting disease severity, in predicting infectivity in the SARS-CoV-2 transmission. We all know that viral load is an important factor in determining the likelihood of transmission of COVID-19. Aggressive contact tracing will aid in quick isolation of high viral shedders who may play an important role in infection and transmission among their contacts. Resource-constrained settings warrant measures that will save the time and efforts in identification of individuals who need to be prioritized and isolated. The cycle threshold values generated in RT-PCR assays have an inverse correlation with the viral load of the person infected with SARS-CoV-2. A positive association has also been reported between sputum viral load and disease severity, the risk of intubation, disease progression, and mortality also. With an assumption that CT values of diagnostic RT-PCR assays represent the viral load as a surrogate marker, we intended to determine its association, whether CT values could be used to estimate infectivity in terms of secondary attack rate, and also its association to common variables like age, gender, symptom status, and comorbidity among COVID-19 positive individuals to inform public health surveillance about utility of the CT values in resource-constrained settings like ours. Next slide, please. In order to find this, we intended to compare the cycle threshold values between the secondary attack rates of COVID-19 positive individuals. We also compared the cycle threshold values by age, sex, symptom status, and comorbidity of COVID-19 individuals. Next slide, please. We extracted data of 485 lab-confirmed COVID positives in 3 districts of Tamil Nadu state, reported in 3 days from the State Public Health Laboratory. We took variables of age, sex, and CT values from the lab's sample referral forms available with the laboratory. We extracted details about symptom status, comorbidity, and number of contacts who tested positive from the district surveillance records. Next slide. We calculated secondary attack rate of the list of COVID-19 positives. We then divided them into quartiles, 4 subgroups of secondary attack rate with less than 25%, 25 to 50%, 50 to 75%, and more than 75%. We calculated the median with interquartile range of the CT values for all the 3 SARS-CoV-2 genes, the E gene, the RDRP gene, and the ORF1b gene. And we also compared them by age, sex, secondary attack rate, symptom status, and comorbidity status. We tested between the groups using Mann-Whitney test, and we report 2-tailed p-values for significance. Next slide, please. The results, the median CT value across 3 genes ranged closely from 22 to 23. Next slide, please. The difference in median CT values of all the 3 genes was not statistically significant across subgroups of age. Next slide, please. Females had a significantly lower CT value in RDRP gene compared to males. Next slide, please. With the subgroups of secondary attack rate, there was no statistically significant difference of the median CT values across all subgroups of secondary attack rate. Next slide, please. COVID-19 positive individuals with symptoms had lower CT values in all 3 genes, with statistically significant difference in the E gene and RDRP gene. Next slide, please. There was no significant difference in median CT values between individuals with and without a comorbidity. Next slide, please. At the outset, CT values were not associated with secondary attack rate for SARS-CoV-2 in our setting. However, we have not accounted for contacts who have not been tested and for unknown confounders with relation to the cycle threshold numbers. This would have influenced our observed association of secondary attack rate with CT values, in addition to estimating the secondary attack rate itself. The symptoms and comorbidity status are self-reported. This information bias, if any, would have led to subgroup misclassification, thereby influencing the association with CT values. Also, CT values can vary based on the sample collection, type of sample, workflow, standard curve, and interpretation of the assay. However, we report findings from a single lab, assuming that the operational biases are nullified in this process. Next slide, please. In conclusion, from our study, symptomatic COVID-19 positive individuals have a significantly lower CT values, corroborating with a higher viral load among them. CT values are not associated with secondary attack rate for SARS-CoV-2 infection in our setting. Thus, CT values may not be of use in public health surveillance to predict the transmission of SARS-CoV-2 infection. Next slide, please. I would like to thank Dr. Manoj Morekar, Director of ICMR National Institute of Epidemiology, for his guidance, constant support. And I also thank the district surveillance teams of Kanchipuram, Thiruvannamalai, Ranipet, and Dr. Selvaraju for his contributions in data collection and analysis. Thank you.
Thank you, Dr. Suganya, for this wonderful presentation. Any questions from the audience or the participants? or fellow presenters? So let me ask you, the CT value been estimated only from the positive cases of COVID in your analysis, right?
Yes.
Or only positive cases?
Yes, ma'am.
So you said symptomatic patients had lower CT value compared to asymptomatic patient.
Among positive individuals. Yes, ma'am.
Okay. So what do you think we have added value? Because you said there is no much public health study. So do you recommend us to do CT value for the cases, or what do you think from your experience?
There has been growing evidence, and I was not looking at the clinical aspects of a clinical perspective. I wanted to know if CT values could add some value to the public health surveillance, public health perspective, because by and large, we need some saving some resources by means of CT values and by giving the CT values to the district. So I think further research is needed in this area, especially when it comes to public health implications of usage of CT values. I think my study could conclude that symptomatic individuals have a higher viral load and they could be viral shedders and they could be isolated. But there's not enough evidence from my study to recommend it as for policy.
Yeah, I was thinking the other way around. So the lower the CT value, we don't have to do anything to the contacts, so that we can just leave them because they are not going to be that infectious, right? So I was thinking the other way around. So any questions from the floor? Okay, that's a question from Datuk Fazila from Malaysia. CT value is dependent on the test kit used. What was the test kit used and what was the normal value used?
I'm not sure about the name of the test kit used by the State Public Health Laboratory, but the reference value that they used to detect positivity was, the upper limit was 34 cycles.
Hello, this is Jiaping Su from Taiwan. So I was just wondering, can you talk a little bit about your, did you do the all tests on the same machine? Just as far as I know, the CT value is dependent on the not only test kit, but also the PCR machine. So did you do all the tests on the same machine? Thank you.
Yes, sir. All the tests were done by same set of people using the same reference value. That is why we took the data from 3 days, 3 continuous days from only a single lab. So we were making sure that the CT value differences from other labs could be a possibility. It has been said that the reference value is different for different labs. So we made sure that we analyze data from a single lab to nullify those other factors.
Dr. Suganya, there's a question. What specimen were used for testing?
Both nasopharyngeal and throat swabs were used.
We give few more minutes, see whether people are typing in or not. Okay, that's one more question from Meng Yu Chen. Was serology test included in your surveillance?
In the study participants, we did not use any serology data. This is just data from the RT-PCR assays.
Okay, if there is no more questions for Dr. Suganya, I would like to thank you for sharing your finding and also your research, what you have done. Thank you so much.
Thank you
I
so
think
much.
we have a few more minutes with all of you all. I think Alden have asked one more question, I think to you, Suganya. What is the relationship between CT value and sample collection? More virus in sample will have lower CT value. So what?
I guess there is an inverse correlation. The CT values is technically the number of cycles that is necessary to spot the virus. So it's a relative measure of the viral quantity. The higher the viral load, the lesser cycles we require to identify the virus. So there's an inverse correlation between CT values and the virus in the sample.
Thank you. And I'm not sure if Surendra is still there. I think there was one question for you from Eldon about your strategy on cluster. He says, do you think this cluster, I'm not sure whether Dr. Surendra is here. Are you here, Dr. Surendra? I think he has left. He's not here. So any other questions for all these four presenters? If anything, we have a few more minutes that we can take up. And there's one more question. This is for Suganya too. For secondary attack rates, you only reported the percentage. What was the number of secondary cases? Unmute yourself, please.
I'm sorry, at the back of my mind, I could not remember the exact number of secondary cases. I can get back to him on that one by referring to my analysis.
Yeah, okay, that's fine.
Sorry, Dr. Tilaka, it's Angela from Taiwan. So I have a question for Suganya, just to follow up with the last question. That was actually my question. Is that what I'm concerned is that, you know, when you only reported the secondary attack rate, we did see some that have very, very high secondary attack rate. So how were you looking for these secondary cases? Were they like within households, and do you think, you know, the different contexts of finding these secondary attack rates would affect your findings? Thank you.
Yes, thank you for the question. I was looking forward for the question to explain what are these secondary cases. We had actually, this is a work of the district surveillance. So the district surveillance teams conduct contact tracing, and they have a specific definition. Primary case and secondary case. A primary case is a primary contact and secondary contact. A primary contact is a person who is ideally from the household of the individual, positive individual. The secondary contact are those people from work, the people they meet in travel, and the people they had communicated or they had come in contact with in the past 3 days. So it is kind of blurry that who are the primary cases and who are the secondary cases. So when I started inquiring it, I just took the positive case in our study sample as the index case and traced all the contacts possible, took all the contacts, both primary and secondary, and found and identified who among them turned positive. So my secondary attack rates numerator would be the number of primary contacts plus number of secondary contacts who turned positive by the total number of contacts.
Thank you.
Okay, thank you. I think since there's no more questions I can't see any questions in the Google Sheet or either in the chat box. So I think with that, I would like to conclude this session by thanking all the 4 presenters who have extremely contributed excellently with all your investigation and also finding, and also given us a lot of information on these 4 aspects today. Thank you so much, and also thank you to the audience and participants for their active question and answer section. And thank you all. Thank you so much for this session, and I will hand over to the Secretariat to move on with today's day 2 conference. Over to you all. Thank you.
Thank you, Dr. Tilaka, and all presenters today. So right now we will going to have a break for 14 minutes. We will have a break for 14 minutes. So please come back and join us again in the next session. Thank you. Good afternoon, everyone. Welcome back to our second session of today's meeting. So right now, I would like to hand over to Dr. Rabani. Please, Doctor.
Thank you for giving me the opportunity. I was going to wait for a little bit for people to let in, but I want to make sure that we have enough time for everybody for their presentation. So I'm gonna go ahead and start it. So welcome and thank you very, very much to everyone in attendance today. I'm Dr. Rabbani Khan, a graduate from Bangladesh FETP program. And currently, I'm working in the Ministry of Health and Family Welfare Bangladesh, and I've been posted as a senior scientific officer at Institute of Epidemiology, Disease Control and Research, IDCR, which is the only epidemiological institute in Bangladesh. And I'm very proud to serve as a moderator in this presentation session. Today, in this session, we have 4 presentations on different perspectives of COVID-19 disease. And I know everyone present here is excited to listen from the speakers. I would like to outline how the session will move forward. The speakers will have 10 minutes each for their presentations, followed by 10 minutes for questions and answer session. May I kindly request all the participants to mute their microphones if you are not speaking. And if you have any question, you can ask at the end of the session. And alternatively, you can also write your questions in the chat room of Google Meet or YouTube. And one small request, please provide your name and agency along with your questions when you are asking questions in chat rooms. Without further delay, let's move on to the presentation. I would like to request our first speaker, Dr. Ajan, who is from EIS South India, to give away the presentation on epidemiology of COVID-19 in Kerala State, India 2020.
Good morning, everyone. Am I audible?
Yes.
Good morning, all of you. I'm Dr. Ajan MC, cohort 2 scholar from India, EIS South in National Institute of Epidemiology, Chennai. I'm currently working in the Directorate of Health Service and in the State COVID Control Room, Kerala. Today, I'm going to present to you on the epidemiology of COVID-19 in Kerala. Next slide, please. Let me bring to you how the whole event unfolded. It all began as a cluster of pneumonia cases of unknown etiology in Wuhan city of China. And slowly the disease left the mainland China and started appearing in nearby countries. And it reached the Indian subcontinent by January 30 in the Thrissur district of Kerala. Next slide, please. And by October 31st, 45 million confirmed cases of COVID-19 have been reported worldwide, including 1.1 million deaths. Next slide. Before going into the setting, let me introduce you to the state of Kerala for all who may not be knowing. It is a state on the southwestern Malabar coast of India with more than 34 million population and population density of 890 per kilometer square. The state also has a high human development index of 0.78 with 12% elderly population and a significant immigrant population of more than 2.1 million. All these factors are very important in predicting the course of infection. Next slide. And as on October 31st, the total cases reported in Kerala is 0.43 million and compared to India with 8.1 million. Next. Next. And the active cases as on October 31st in Kerala was 0.09 million and in India was 0.58 million. Next. Next. The objective of my study was to describe the epidemiology of COVID-19 in Kerala, India during January to July 2020 by time, place, and person. Next slide. We did a cross-sectional study on all the confirmed COVID-19 cases in Kerala from January to July 2020 using the state surveillance data, which is cleaned and analyzed using EpiInfo version 7.2.3.1. Next slide. Before going into the result, I would like to describe further a little bit about the COVID-19 surveillance system in Kerala, which is established. For a traveler coming to Kerala or a contact of a positive case, they have to remain in home quarantine for a period of 14 days And if turned symptomatic, they have to get tested at the labs. And if turned positive, they will be admitted to either COVID hospital or COVID first line or second line treatment centers, or they can opt for staying at home or domiciliary care center for a period of 10 days, following which they will get tested. Admission to these facilities are based on the severity of symptoms and comorbidities. Next slide. Over the period, the surveillance system has undergone several changes. And after establishing the surveillance system for COVID on Jan 24, the testing guidelines got changed by including returnees from countries notified by World Health Organization. Then public health mitigation strategies such as break the chain campaign, universal usage of masks were implemented during the month of March and April. And sentinel surveillance was testing was established from May 14, and antigen testing was introduced from July 2nd onwards. Next slide. The case definition which we adopted was for a confirmed case of COVID-19 was a person with laboratory confirmation of COVID-19 by either RT-PCR, TrueNAT, or rapid antigen testing, irrespective of clinical signs and symptoms in Kerala. Next slide. On analyzing the study population, the median age was found to be 35 with an interquartile range of 25 to 48. 77% of the study population was between the age group of 20 to 60. 68% were males and 41% were travelers and 3% were healthcare workers. Contact tracing process was also expeditiously done and was able to trace out an average of 7 persons per case. 111 deaths also occurred during this period from the study population, and with a case fatality rate of 0.4%. And the cumulative sample positivity was 3% at July 30. Next slide. An epi curve was plotted to show the time distribution by date of reporting of cases. 3 cases were confirmed during January and February, and then again the cases started appearing on March first week, and till lockdown was enforced on March 24. And after the lockdown relaxations were implemented, permitting interstate and travelers and repatriation flights to come, cases started increasing, and further rapid increase occurred after sentinel surveillance was expanded and antigen testing was enforced. Next slide. The incidence in administrative districts were also calculated. Initially, in almost all districts, it remained below 100 during the month of May and June. But in the month of July, in the border sharing districts like Thiruvananthapuram, Pathanamthitta, and Kasaragod, the cases and incidence went beyond 1,000 per million. Next slide. Age-wise attack rates was also calculated and was found to be 990 and 801 in age groups of 20 to 40 and 40 to 60 respectively. In males, the incidence was more than twice as compared to females. Next slide. The probable source of infection was also found out, and it turned out to be 40% travelers and 54% contacts. 5% of the cases had no contacts or travel history traced at the time of declaration. The districts were arranged in the descending order of traveler history in the graph plotted here, and it was different in different districts, and Palakkad had the highest proportion of 70%. Next slide. The reported symptoms among the COVID-19 cases at the time of admission was also analyzed, and it was found that 27% of the cases had fever, followed by cough and sore throat, and 24% of the cases were asymptomatic at the time of confirmation. Next slide. Another point to mention was on cases which presented with a single symptom or the only symptom to be presented at the time of admission, fever was the most common symptom in 35% of the cases, followed by breathlessness, nasal discharge. Next slide. The mortality or the deaths which happened were also analyzed, and among the 111 deaths which happened, 103 had comorbidities, and among the comorbidity, diabetes was the major contributor with 56%. Case fatality rate was also calculated and was found to be 3.45% among more than 60 age group, and with a total case fatality rate of 0.47. There was not much of a difference between the case fatality rates of males and females. Next slide. Doubling time was also calculated, which is hovering around 14 to 16, and hospital infrastructure and ICU beds were planned based on this doubling rate predictions. Next slide. The COVID-19 test by method of testing was also plotted to find out how the testing method changed. Initially, for all the 0.7 million tests done till July 31st, the number of tests done per day was initially less than 1,000 and was mainly RT-PCR, and it later got shifted to antigen, as you can rightly see from the graph. Next slide. The distribution of COVID-19 cases, daily persons tested, and test positivity was by date of reporting was plotted, and a component bar chart was made with log to the base of 10. And we could see that the test positivity was fluctuating and from 1 to 6, but lately showing a steady upward trend and should be focused upon as a predictor of the future increase in cases. Next slide. Moving to the conclusions which we arrived upon from our study, the proportion of cases with contact history and unlinked cases were increasing after the travel resumed after lockdown and sentinel surveillance was increased. The incidence of COVID-19 was highest in border sharing districts. The testing capacity was scaled up first by increasing RT-PCR and later by antigen testing. And the incidence of COVID-19 was higher in 20 to 60 age group. And point worth mentioning was mortality was higher among persons with comorbidities and in elderly population. Next slide. The recommendations which we arrived at are as follows. That is, to increase the community testing in areas where clustering of cases or unlinked cases are found, and case investigation and contact tracing need to be intensified, and data on high risk and low risk primary, which is not available at present, need to be collected. EC and BCC should be focused on the 20 to 60 age group, and strict preventive measures should be followed by this group, as they can bring the disease to the vulnerable population at home. And let me remind you, Kerala is having an elderly population of more than 12%. And reverse quarantine need to be ensured among elderly and those with comorbidity to prevent such mishap. Next. With that, I would like to conclude my presentation and would like to thank my mentors and faculty at the National Institute of Epidemiology, my colleagues at COVID Control Room State, and the conference organizers, my Director of Health Services and Health Secretary for the wonderful opportunity they have all provided. Thank you once again.
Thank you, Dr. Rajan, for sharing the distribution and magnitude of COVID-19 disease in Kerala, and also stating the importance of surveillance in prevention of infectious disease like COVID-19. The floor is now open for question and answer session. So if anyone wants to ask any questions, we have couple of questions in the chat room, but I will go if there are any questions from the participants. Okay, I think let's go with the questions in the chat room. So first question for Hari Shankar. So his question is there any advantage of community isolation compared to home isolation? Dr. Rajan.
Yes. Home isolation and community isolation, I didn't get. Can you please elaborate on that?
So is there any advantage of community isolation compared to home isolation?
Okay. For home isolation, we could found that most of the persons, those who are having capacity to be for having a home isolation, they would prefer to stay at home because all the surroundings and all are familiar to them. And the surveillance which we established was that daily calls were made to them to ensure their health status, And if at all they are having any symptoms, they were asked to report, and an ambulance was provided to them to bring them to the health facility. And it was not advisable for those who were having any comorbidity at the time, and uncontrolled comorbidities, like, for example, diabetes and hypertension. If at all that was the case, they were not allowed to be in home isolation, and they will be shifted to COVID first-line treatment centers. Thank you.
Okay, thank you so much. So another question from Dr. Kayati from India EIS. Were all travelers from outside quarantine for 14 days?
Yes. And all, it was like the system we established in the state of Kerala was, all those who want to come to Kerala, they had to register first in a portal named COVID-19 Jatudha. And if at all, after registering in the portal, a pass which will be issued, and with that pass only they can come to Kerala. And after that, the rapid response team at the local self-government level were ensuring that they were sticking on to home quarantine and all.
Okay. So there's another question. So what is the meaning of reverse quarantine? A question from Hansa Varakul.
It is like a quarantine is what we use for those with at risk, for those who are suspected to be having an infection. And reverse quarantine was defined for those who are comorbidities, elderly persons. They should also be protected and should be isolated from the disease which was circulating outside. That was which we used and which we promoted with IEC in state of Kerala, and it has quite worked well.
Okay. So, so moving on to the next question, it's from Meng Yu Chen. So interestingly, he wants to know that, see the difference in the incidence by gender. Do you think it's because of the biological factor or due to the access to testing? Any difference in test positivity rate by gender?
It is actually because for the initial period, all the returnees and all were migrant workers and all outside. Most of the cases, as you can see, 20% of the cases were travelers. And during that period, most of the returnees were males also. And that's the reason why it's actually fluctuated. And Kerala being a highly literate state, and also with everybody having an access or accessibility to test at course, people can go and test, and there is no difference in gender, so that people, male can test only, something like that.
Okay. So next question is, when was the first unlinked case identified? And will that count as community transmission? It's from Purvi from India.
The first case, as I already mentioned during my presentation, the unlinked cases of our 5% unlinked cases, which you say, that is at the time of declaration of the case. And we have done extensive investigation to find out whether there are any linkages to the cases. And we could, for the initial part and all, we could find most of the cases to be linked to some case or other. And the initial unlinked case was reported, or which we couldn't trace to something, was around April, May.
Okay.
But
So,
as a point was community transmission was raised, what we did to ensure or to examine the possibility, we tested all the contacts, all the possible contacts of those cases, and we couldn't expand the case count from that. And that's why for the period of May and June and all, community transmission was not different.
okay, thank you. So another question from Angela Huang from Taiwan FETP. So how did you decide who gets PCR testing and who gets antigen testing? And did the positivity rates differ?
Yes, it's like as already was present in the slide. Can you take me to the slide 20? Hello? Yes. Slide number 20, please. Yes. As you can see, antigen testing was introduced in the month of July, Until then, we had RT-PCR and TrueNAT testing. And TrueNAT testing was employed for emergency surgeries, deliveries, and all. And antigen testing was more or less be done at the community areas where more and more cases started reporting to rule out community transmission and all. And all the symptomatic, if at all a symptomatic case is negative in antigen testing, that person will be subjected to RT-PCR testing. And as mentioned, RT-PCR had more positivity because it was done more on high-risk suspects. Yes.
Okay, we are running out of time, so we have so many questions in the chat box. So I think I will take one or two. So one question from Bina Rai: did you have enough resources to make sure that all complied to the quarantine? And what happens if they break quarantine? And what do you know about it? So.
It's like what we ensured was initially it was advised that all those returnees should be placed at institutional quarantines. I mean, we had set up institutional quarantines at all districts, but later we found that, as already mentioned, the number of returnees are by and large very huge in Kerala compared to other states and all, and people were very wanting to be at their homes. Many of the persons have got good facilities for ensuring room quarantine or home isolation at their residences itself. So it got shifted to that policy decision, and people were allowed to be in home quarantine. And those who broke home quarantine or broke the laws of quarantine, Epidemic Act was enforced in Kerala, and as in all over India. And cases were actually taken against them. So people had such sort of fear also. So most of them, we had very few instances of quarantine breakage. Yes, thank you.
Okay, so Dr. Rajan, I think you can also access to the chat box. So it would be great if you can answer those questions in the chat box. That would be great. So one last question from my side: that how did you actually define the contacts in the study?
Like the contact definition which we used to was adopted from the World Health Organization and also ICMR. And right from the beginning itself, we had contacts definition like high-risk primary contacts and low-risk cases. Like contacts with a confirmed case of COVID-19 or a traveler with who visited a hospital where COVID-19 are being treated. Or where a place where local transmission is being reported, or who touched body fluids, those were categorized as high-risk cases. And low-risk cases were like shared the same space, an open space, travel in the same environment, but not having high-risk exposure, like that.
Okay. Thank you, Dr. Rajan, for your answer, and thank you all for your lively participation. I would like to request Dr. Rajan to respond to the questions raised in the chat box, please.
Okay, with pleasure.
Thank you. Thank you. So moving forward to our next presentation on effectiveness of airport screening for COVID-19 at Taiwan International Airport, January to June 2020. This will be presented by Ching-Wan Seng from FETP Taiwan. Pardon me if I pronounce the names incorrectly. So dear audience, Ching-Wan Seng from Taiwan FETP.
Good afternoon. Next, in response to COVID-19 pandemic, many countries have conducted travel-related control measures to contain the transmission of Entry screening are measures conducted at the point of entry on travelers arriving to a country to assess travelers' risk of having COVID-19 and prevent disease introduction to the country. Activities include observation of travelers' symptoms and signs, temperature measurement, health quarantine, lab examination, and ordering isolation, quarantine, and travel restrictions. Next. Several COVID-19 measures have been taken at the Taiwan border. Next. when COVID-19 outbreak emerged from Wuhan, China. Quarantine officer at the airport conducted on-board health assessment for all flights arriving from Wuhan. Next. Since January 24, all passengers arriving from COVID-19 high-risk country are asked to complete a health declaration card. They are also subjected to a 30-day post-entry quarantine. Next. Since February 6, travelers who were suspected to have COVID-19 will get tested on-site at the airport. Before then, travelers were sent to hospital for sampling. Next. As COVID-19 spread across the world, high-risk countries have updated several times. At first, it included Wuhan, then expanded China in late January, and then to Asia, Europe, and Americas in late February, and to all countries since March 19. Next. Here is the entry screening and quarantine process. At the point of entry, passengers arriving from COVID-19 high-risk countries need to complete a health declaration card to report COVID-19-related symptoms or possible contact. Thermal scanners are set to detect feeble passengers. Next. Quarantine officers then assess passengers who report symptoms or are feeble and determine if passengers meet the case definition current at that time. Next. Those who do not have symptoms, do not meet the case definition or test negative, will undergo self-management for quarantine for 40 days. Next. Those who do not have symptoms do not meet the case definition for test negative, will undergo self-management or quarantine for 40 days. Next. The case definition for suspect COVID-19 cases has changed over time. In January and February, the chronic criteria was fever and respiratory illness. Later, it changed to fever or acute respiratory illness. In late March, GI illness, abnormal smell or taste tube were added. In January, China was the only epidemic area. In February and March, high-risk countries include countries in Asia, Europe, and the Americas. Since March, all countries in the world are considered high risk. Next. The case definition for confirmed case COVID-19 cases is a person who tests positive for SARS-CoV-2 RT-PCR at the point of entry or after entry to Taiwan. Next. Our objective is to evaluate the effectiveness of entry screening for COVID-19 at the Taoyuan Airport, which is the largest international airport in Taiwan. Next. We use the data from the National Quarantine Surveillance System. We extracted data all inbound passengers at the Taoyuan Airport during January 1 to June 30, and their data of arrival, symptoms, and the PCR testing result. We calculate the case detection rate, sensitivity, and the possible predictive value or PPV of airport screening and examine the change by month. Next. Case detection rate was calculated as the number of confirmed cases of COVID-19 detected at the airport per 1,000 passengers screened. Sensitivity was the number of confirmed cases detected at the airport as a proportion of the total number of impacted cases. PPV was the proportion of symptomatic cases who tested positive for COVID-19. Next. During the study period, nearly 2.9 million passengers arriving at Taoyuan Airport. Next. Over 10,000 had symptoms. Next. 6,047 meet the case definition of suspect cases and testing for COVID-19. Next. Passengers who had no symptoms or do not meet the case definition were non-suspect. They passed through the airport without testing. Next. Of the 6,047 passengers tested, 131 passengers were confirmed cases to have COVID-19. Next. The overall case detection rate of screening of 0.05 per 1,000 passengers. Next. The case detection rate increased in March and peaked in April, when countries in Europe and Americans experienced at the first wave of COVID-19. The case detection rate decreased after. Next. Additional 218 imported confirmed cases passed through the airport without testing, but were detected during home quarantine. Next. As a result, the sensitivity of entry screening for COVID-19 was 37.5%. Next. Sensitivity increased from 10% in February to 88% in May. Repeated adjustment of the case definition during February and March may lead to increase in sensitivity. Next. Of the 6,047 suspect cases, 131 was confirmed as COVID-19. PPV was entry screening was 2.2%. Next. PPV varied by month, a range to 0.2% to 20%. The PPV in January was the highest, probably due to smaller number of passengers from Wuhan, China, but a high prevalence of COVID-19 impacted passengers from Wuhan during that time. Next. In summary, almost 2.9 million passengers underwent entry screening at the Taoyuan Airport during January to June 2020. We detected 131 COVID-19 confirmed cases through the screening. We find the airport screening for COVID-19 had moderate sensitivity but a low PPV. Next. Our study has a limitation. First, passengers' health status was self-reported, so there is a potential record and response bias. Second, not all passengers were tested at the point of entry. We may miss some asymptomatic or pre-symptomatic cases. Next. Our recommendation include to continue entry screening at the airport, to continue monitoring sensitivity and the PPV of the screening, to identify cost benefit or potential harms related to screening, and to set criteria for discontinuation or discalculation of screening. Next. Thank you.
Thank you, and congratulations on your presentation, Dr. Ting Wan Tseng. It's a very nice one, and it's very important to measure the effectiveness of the screening program in the airports, because all the countries were affected most of the countries were got affected through COVID-19 through the imported cases. So if we can strengthen this point of entry screening, then it will be definitely much more helpful. So moving on to the question and answer session, we had a question from Dr. Amit Razivan. So he's from EIS program in Chennai, India. So he wants to know that, can you tell something more about your national quarantine surveillance system? Dr. Singh.
Hello, everyone. I'm Dr. Chen from Taiwan CDC, and I'll help with the translation. So I'll speak to Dr. Chen in Mandarin and then explain the question, and then she will respond in Mandarin, and I will help with the translate into English. Thank you.
Okay. So I repeat the question. Can you tell something more about your national quarantine surveillance system? So, am I audible?
Excuse me, may I have 检疫系统就是，我们在就是旅客入境的时候，我们就是会收集旅客的相关的症状资料之后，我们会将他的症状资料会进入在我们的系统里面。那之后这些资料就会上传到我们的系统。那当旅客进入到社区的时候，我们的社区的防疫系统就可以知道这个 case， 那我们就可以启动追踪。
So in terms of our national quarantine system, we collect data in terms of traveler symptoms or date of arrival, and also the country traveled. And because of COVID, we also collect testing results. And then all the data were put on our surveillance system and will link to the another quarantine system, and then other passenger could be followed even after their entry.
Okay, thank you. So I will just wait for some more of the questions in the chat room. So in between them, I have a question for you. So definitely, airport screening is most important, and it involves a lot of resources that are used for other activities during the airport screening. So what condition would you recommend using a airport screening to prevent the importation of cases?
OK， 好，我们透过简易的这个 screening， 我们能够知道，当旅客入境当下的时候是不是有症状。那他假如在境外有症状的时候，我们也可以及时去做拦检的动作。谢谢。
If I understand, the question is asking when and what time we would implement the entry screening to identify the imported case. So in Taiwan, we already have, because of the after SARS, we already implement the quarantine surveillance at the point of entry. And we also apply that system to detect other imported cases, such as, the imported disease like measles or dengue. So we apply that structure to detect COVID, the emergent infectious disease, and COVID-19. We do know this take a lot of resources. That's why we try to evaluate the effectiveness of these measures, and we found that indeed it already detect like more 30% of imported cases. So that still kind of have some value for this screening process.
Okay, thank you. So we have another question from Manikandas Nisan. Sorry. So was the positive predictive value analyzed by countries? And if yes, which country has the highest PPV?
May I have 37 slide? 目前我们就是找到的最多的国家就是英国，再过来是美国。那英国部分是占31%，那美国有26%。
So during the study period, which is January to June 2020, the most cases, imported cases, detected at airport are from United States and European countries.
Okay, so another question from Dr. Pormarzi from Australia. So do you have any explanation for the decreased sensitivity after May 2020?
他是问说什么时候，为什么3月以后的 sensitivity 会下降？5月以后的 sensitivity 会下降。
I think after May, the number of imported cases decreased, probably because of the slowly down of the epidemic, of the global epidemic.
Okay. So going to the next questions. What the success rate of the few validated point-of-care testing vis-a-vis the high-definition PCR testing methods in your country or even globally?
We have not used the POCT. We have used the RT-PCR test.
Okay. So one question from Myanmar is Dr. Sain Playing. What are the recommended factors to be considered for decision-making on relaxing entry screening on airport?
问说怎么样让你决定要继续使用这个 airport screening 这样子？
你说要继续使用 screening？那我们是会监测我们的 sensitive。好，我们就是会持续监测我们的敏感度跟我们的 declaration rate。那假如我们的这些的数据是有持续上升的话，那我们还是会继续做我们的入境的筛检的部分。
We can see that So with the adjustment of case definition during the study period, we can see the sensitivity of the entry screening increase. So that's why we recommend to continue monitor the sensitivity and positive predictive value to see the effectiveness of screening. If we see the decrease of sensitivity, we may to evaluate why was that, and we also recommend to further investigate the cost benefits related to screening, because we do know that it takes a lot of resources, and it also depends on the country's context. Like Taiwan is an island, so there's a lot of imported case even at this moment. So we still think that entry screening, we still require entry screening to prevent the cases imported or even to prevent the imported case into our country.
Okay, thank you. For last question for you, did you collect data on travel purposes? And how did positive predictive value vary by purpose of travel from 1.
我们最常见的就是从在国外的念书的学生，或者是在境外工作的工作人士回台的。
Most cases they work or study abroad, but we don't have the exact number. But we believe at that time most people were working or studying abroad.
Thank you so much, and congratulations once again, Dr. Singh, for your nice presentation, and thank you all the participants for their good discussion. We would like to move to the next presentation. I think Dr. Ayu Naraswarianesa, are you there? Yes, I see you from FETP Indonesia. So she will be presenting on characteristics and determinants of confirmed, asymptomatic, suspect, and probable COVID-19 cases in Bali province, Indonesia. Over to you, Dr. Ayu Naraswarianesa.
Okay, yes, I'm here. Good afternoon, everybody. Thank you for the opportunity given to me to present my study entitled Characteristic and Determinants of the Confirmed Asymptomatic, Suspected, and Probable of COVID-19 Cases in Bali Province. I'm Niputu Ayu Naraswarianesa, in a team with Ana Agung Sagung Sawitri, who is my supervisor, and Iwayan Pujana, a staff of Local Health Department of Bali Province. Yes, please, next slide. Coronavirus disease 19 or COVID-19 is a global pandemic disease that's still threatening global public health. Indonesia is one of the countries in the world that affected by the disease with more than 10,118 cumulative cases have been documented occurred. Of 34 provinces in Indonesia, most of them have been infected with the disease, including Bali. The cases of COVID-19 in Bali have attracted the global attention as Bali is a famous for the tourist destination in the world. Until April 2020, more than 200 of the confirmed cases have been recorded, with 130 cases recovered and 4 dead. However, studies related on the COVID-19 in Bali are still limited. Yes, please, next slide. Therefore, this study aims to assess the characteristic of the COVID-19 infection in Bali by assessing the distribution of them and identify its determinant. Next slide. A cross-sectional study was conducted using secondary online published data input from January 19 to April 30, 2020, gathered from Department of Health Bali Province. Sample units used in this study were 459 persons who suspected and or probable COVID-19 infection confirmed by diagnostic PCR. Data of the characteristic, including the distribution, were descriptively analyzed, while the potential determinants were analyzed by using bivariate analysis with the chi-square test. Variables that had p-value less than 0.25 were then tested by using logistic regression for the putative determinant. Next slide. In this result, among the 9 regencies and a city in Bali, the top 3 of the areas distributed with the COVID-19 cases were Denpasar City, occupied 23.1% of the total samples, with 20% confirmed case and 21.5% negative. Then Buleleng Regency with 14.4% of the total cases and 10.6% diagnostically confirmed and 17.5% negative. Whereas Gianyar Regency had 13.3% of the total cases with 11.1% confirmed case and 15.1% negative. Next slide. In the characteristic of the COVID-19 cases in Bali, this study found that more male were infected than female, within 65.6% in males against 34.4% in the females. Range age of 26 until 35 years old had the highest incidence of the disease, filled with 37.3% of the cases. Meanwhile, in the occupation, cruise ship crew had 35.5% of the cases, whereas in the domiciles regency and city of the COVID-19 distribution in Bali. Next slide, please. Denpasar had the highest percentage with 23.1% compared to the other areas. Similarly, having a historic contact with COVID-19 case before had 41.8% compared to the other risk factor. Yes, please. Next, please, slide. From the confirmed cases, it is interesting to acknowledge that 73.2% of the suspected cases with COVID-19 related symptoms diagnostically negative infected with the virus, whereas 50.2% persons with the PCR positive test had no symptoms of the infections. Or the 59 confirmed case, 19 showed clinical symptoms and 162 without showing symptoms. Next slide. Based on the multivariate analysis test, the variables of occupation and risk had p-value less than 0.05. It means the putative risk factor of the COVID-19 were occupation, the cruise ship crew, and the risk having historical contact with the infected person or COVID-19 cases. Occupation of cruise ship crew were 8.119 more likely infected with COVID-19 than non-cruise ship crew, with P less than 0.0001. Additionally, someone who had contacted with COVID-19 infected person were 1.436 more likely having the infection than someone with the historical no contact. Next slide. In this discussion, the high proportion of COVID-19 in Bali is likely associated with symptoms and without symptom case. In addition, screening tests performed at the airport and tracing the cases might contribute to the high proportion of the case. Denpasar had the highest confirmed case. It's actually beyond of this study. However, the high density population in Denpasar may be one of the factors involved in the cases. The cruise ship crew is a risk factor. At this time, many international migrant workers have returned home since January 2020. At the airport, screening of migrant workers using rapid test was enforced, and if they were reactive, a confirmation test was carried out. In addition, all migrant workers were isolated in certain buildings. Another risk factor is having contact history with COVID-19 cases. All persons recorded in the website data is related to COVID-19, including the history of contact with confirmed cases. Awareness about transmission were not yet well developed in the community level. The limitation of the study are PCR limited and input data incompleteness that influence the limited variable being analyzed. Next slide. In this conclusion, it is conclude some characteristic of COVID-19 infection found in Bali, such as more men were infected found along in the study period. Majority of the cases were resident in Denpasar, Buleleng, and Gianyar. Denpasar had the highest confirmed cases of COVID-19. In some related cases, found cases with diagnostically confirmed infected had no symptom, while in some other cases also found the suspected cases with related symptom but negatively confirmed. Cruise ship crew and having historical contact with COVID-19 cases might likely be the risk factor of the infection in Bali. However, more studies and data required to assess more about the COVID-19 infection in Bali to have more understanding and knowledge related on this disease infection in the area. Next slide. That's the end of my presentation. And finally, thank you for your attention.
Thank you so much, Dr. Naraswaran Nisa, for your nice presentation. Yes, we had a good idea on the distribution and determinants of confirmed cases in Bali, Indonesia. And you raised an important point that as it's a tourist place, Bali, Indonesia, so there's more chance, more likely to be spread of infection. So we have some couple of questions. First question from, two questions from Dr. Masum Billah from Bangladesh. So first question is, what was the criteria for testing COVID-19 in Bali, Indonesia? Should I repeat you the question again?
Okay. What was the criteria for testing COVID-19? In Bali province, data from the website were input from the Bali Provincial Health Office and District Health Office. The data in Bali Provincial Health Office were added from related laboratory data, the Bali Airport and Sanglah Hospital. However, data in the District Health Office were gathered from sub-district level primary healthcare and district level hospital in Bali. I have the data from the district level. I cannot speak English fluently. I invite my supervisor, Dr. Savitri, can help to translate what can I to tell the everybody.
Yes, sure.
Hello, Nesa.
Yeah, thank you, Dr. Savitri, to join this presentation. I have the question, what's the criteria for testing COVID-19? Jadi dari kemarin untuk kegiatan kita yang kita testing itu berdasarkan hasil dari orang yang suspek PDP, ODP, dan OTG. Jadi kita melihat kriteria untuk mengikuti COVID-19. Jadi dia ada kontak terhadap orang yang terkena COVID-19. Mungkin bisa bantu disampaikan, Dok.
Yeah. We tested everybody who have ever contact with the confirmed cases, even though they have or not the symptoms. So as long as they consider as close contact defined by the CDC and the MOH, so it should be at least 15 minutes within the within contact with the cases. It's considered as a close contact. Then they should be examined for the PCR test. That is the criteria. Thank you.
Thank you, Dr. Savitri and Dr. Nisa. So your next question in the chat room from Masum Billah. So was there any COVID-19 outbreak in cruise ship in Indonesia?
In Indonesia, I don't have the data, but in Bali, can I show the slide for the slide 6? Can I show the slide number 6?
May I request all others to please mute your microphone?
Okay, in the characteristic, the cruise ships are 163 frequency and have a 35.5% cases in the cruise ship crew. But in Indonesia, I don't know about the outbreak in cruise ship or not. But in Bali, for the 19 January until 30 April, I have the data like this.
Okay, I think the question is, so there is, we didn't identify any cruise outbreak in cruise ship in COVID-19 in Bali. So you have some outbreak, but the total, the table you showed that the cruise ship crew, so those are the outbreaks in the cruise ships, right?
Yes.
Okay. So moving to your next question from Eric. How did you handle missing data and could this have affected your results?
If I have a missing data, I close or I don't use. I have 3,017 data, and the data had a PCR test just for 159 sample. And then 208 with the positive cases, the confirmed cases, and 259 is a negative confirmed case. Dr. Savitri mungkin bisa dibantu, di luar data itu kita tidak gunakan sebagai sampel ya.
Yeah, may I add some information about the missing data? So even though we have around 3,000 sample, but actually in March to April we have a policy not to examine all contact, close contact with the PCR test. So at that time, the policy is more to examine the people within rapid test. And if the rapid test is negative, then it's not being followed with the PCR test. Another thing is because the PCR test is very limited at that time. So even in the also the rapid test is quite limited at that time. So many people who already isolated self-isolated or isolated in the, for example, in the building settled by the government is also not being examined by the rapid test. So the 3,000 is actually not only contain missing data, but also contain many people who are only examined by the rapid test and or not examined by rapid test, but only being isolated in the settlement building, something like that.
Okay. Thank you, Dr. Saitri and Dr. Nessa. So the last question from Thea from Philippines. So among the confirmed cases who were asymptomatic, did they remain asymptomatic or eventually presented a sign or symptom after being tested?
Can I show the slide number 8? Dr. Sawitri, mungkin ini maksudnya apakah dia terlihat gejala lagi setelah dites?
We can hear you. Can you unmute?
Oh.
Nessa mau menjelaskan atau saya menjelaskan?
Langsung dokter aja dah, dok.
Yeah, okay. So we have actually that we have the policy if someone being positive, then we have to follow up until 14 days before they can be released from the isolation. However, we don't have any data for follow up. So actually, we don't know whether the asymptomatic person then having a symptom after the follow up. Yeah.
Okay.
So yeah, we cannot answer the question. Thank you.
Got it. We got it. So thank you, Dr. Saitri and Dr. Nessa, for your nice participation, and thank you again, the audience, for their participation. So moving to our last presentation from Kasmira Maramang from FETP Philippines, and she will be describing COVID-19 cases in 3 detention jails, a case control study, Metro Manila, Philippines, April 2020. Dr. Kasmira Maramang.
Good afternoon. I am Maria Casmira Maramag, FETP Fellow, and I'm here to present the findings on our case control study on COVID-19 cases in 3 jails in Metro Manila, Philippines, conducted in April 2020. Next. The Philippines is an archipelago with an estimated population of more than 108 million. Metro Manila is the capital and the epicenter of COVID-19 in the Philippines. On January 30, we reported our first confirmed COVID-19 case, which was followed by 2 more cases within a week. All were imported cases from Wuhan, China. A travel ban was imposed after. No new case was reported until March 6, when the 4th confirmed case was identified. On March 7, local transmission was confirmed by the Department of Health. On March 15, Metro Manila was placed on enhanced community quarantine. Except for essential workers, citizens were strictly advised to stay home. On March 17, ECQ was expanded to the rest of Luzon. However, cluster in communities and closed settings such as health facilities were reported. Next. Next. Disconnect yata. Wala. On April 18, the Department of Health Event-Based Surveillance and Response received clustering reports in jails A and C. 4 days after, we started epidemiologic investigation on the 2 jails. On the same day, Jail B reported clustering and was included in the investigation. Next. Our objectives were described case detection, specimen collection, testing, and referral to health facility among cases and close contacts, determine the magnitude of the infection, and identify risk and protective factors of COVID-19 infection. Next. For our methodology, we reviewed medical records, interviewed key personnel, conducted active case finding among personnel and PDL, and collected nasal and oropharyngeal swabs for COVID-19 confirmatory testing via real-time polymerase chain reaction. Next, we used the following case definitions. A suspect case is any jail staff or person deprived of liberty who is a detainee, inmate, or prisoner from 3 identified jails who had sudden onset of fever, any respiratory signs and symptoms, or diarrhea starting February 1, 2020. A probable case is a suspect case whose test result was inconclusive or equivocal. Next. A confirmed COVID-19 case is a jail staff or PDL with or without signs or symptoms who tested positive for COVID-19. A close contact is a jail staff or PDL who provided direct care for a confirmed COVID-19 case without proper protective equipment, or a person who had direct physical contact, lived, worked, or transacted in close proximity for more than 15 minutes with a confirmed COVID-19 case. Next, we conducted an unmatched case control study. A case was a confirmed COVID-19 case. In a control was an asymptomatic jail staff or PDL who remained asymptomatic throughout the study and or negative for COVID-19 confirmatory test. Next, for our results. Next. Management of jails are under the jurisdiction of Bureau of Corrections and Bureau of Jail Management and Penology. In January 2020, congestion rate was above 300%. Next. A single size bunk bed placed 2 to 3 feet apart are shared by 4 PDL. PDL are allowed to stay in the common area from 8 a.m. to 4 p.m. They group together with their gang members. They fall in line for ration food and share meals. Jail officers make rounds at least 3 times a day to account for all prisoners. Next, we identified 235 COVID-19 cases from the 3 jails. There were 115 suspect cases and 120 confirmed cases. Next. Of the 120 confirmed cases, 67% were female. Ages were 20 to 83 years old. Most common signs and symptoms were fever, cough, and sore throat. 17% were asymptomatic. 42% had pre-existing health conditions, such as hypertension, diabetes, and asthma. Next. There were 6 deaths with a case fatality of 5%. Majority were males from the older age group. All died due to pneumonia. Next. This figure shows the epidemic curve of cumulative confirmed cases from 3 jails. Jails canceled PDL visitation on March 10 after local transmission was announced. On March 20, jails implemented lockdown days after ECQ was imposed. Only jail staffs on duty were allowed to enter jail and will not leave post until completion of 2 weeks duty, then followed by 3 weeks off. Next. PDL and nurses claimed an increase in fever and respiratory illness starting late February, but were not tested for COVID-19. There were no record of consultation. Only those with life-threatening conditions were allowed to be brought to the nearest hospital and tested for COVID-19. Some of these PDL tested positive on PCR, but results were allegedly not received by the jails. COVID-19 is a notifiable disease that should be reported to DOH within 24 hours upon detection. However, on March 27, cases were detected by JLC but only reported to DOH in mid-April. Next. This figure shows clusters in JLC. Gray represents jail staff and PDL in orange. Initially, there was no symptom screening was done for visitors and jail staff. Medical team in the infirmary was assigned to do daily screening of staff once lockdown was implemented. First reported case was a jail officer, marked as A. She receives PDL visitors and visit other offices for administrative tasks. She does not have a known COVID-19 exposure, but resides in a city where 400 confirmed cases were reported. She recalled assisting a PDL visitor with fever and cough and developed fever days later. She continued to visit other offices, including the infirmary, while symptomatic. Clusters were reported among medical staff, including the admitted PDL and PDL health aide in the infirmary, and among jail staffs monitored by the medical team. All medical staff claimed use of surgical or N95 masks, but gloves, gown, and goggles were limited. Next. One of the PDL who died and labeled as case B had the earliest known onset. He was taken cared of by his gangmates who tested positive at least 3 days. After 2 weeks, case B progressed to severe symptoms and was admitted at the infirmary isolation room. Next. We identified factors associated with COVID-19 infection. Our analytic study showed, next, 19 factors were associated to COVID-19 infection on bivariate analysis. However, after logistic regression, we identified that those who shared a meal were 19 times more likely, those with diabetes 11 times more likely, and in an enclosed space with a confirmed case 4 times more likely to have COVID-19 infection. The risk of COVID-19 infection was lower among those who took vitamin C, no history of smoking, and used alcohol-based hand sanitizer. Next. In conclusion, there was a COVID-19 outbreak in jails. Jails are closed settings where infection is introduced by individuals from the community, such as PDL visitors and jail staff. For these 3 jails, there were no strict implementation of health and exposure screening of any individual entering. Transmission was sustained due to poor practice of minimum health standards, such as masking, physical distancing due to overcrowding, hand hygiene, and PPE for healthcare workers. Limited testing and late reporting led to the delayed detection of cases and contact tracing, causing clusters to emerge. Next. We recommended the following adopting the Philippine COVID-19 response. Prevention and control measures such as use of PPE and practice of hand hygiene, promotion of healthy lifestyle and managing pre-existing illnesses, early detection through disease surveillance by conducting symptom screening in entry and exit, monitoring of health status, and immediate contact tracing. Detected cases should be reported to the local government and regional epidemiology and surveillance unit to assist in the response and coordinate laboratory testing. Identify dedicated isolation facilities in order to immediately isolate and quarantine cases and close contacts, and treat by coordinating transfer of severe and critical cases to hospitals. Next. The DOH disseminated an interim guidelines on the prevention and control of COVID-19 in prisons and detention facilities. The IRR of mandatory reporting of notifiable diseases and health events of Public Health Concern Act was revised, which includes jails to be involved in the disease surveillance and response. Next. Jail staff reported cases detected through consultation and contact tracing. With the assistance of local government units, confirmatory testing was done on site. Jail officers were trained on proper collection and submission of NPS, OPS, and PPE donning and doffing. Face masks were distributed to PDL and jail officers. PPE were made available for healthcare workers. Isolation facilities were established through the help of the ICRC. Streamline the coordination between RESU and hospital for efficient transfer of severe and critical cases. Next. There were cases still detected in jails, but this has decreased since August. Jail C last reported a case in June, and Jail A in October. As of November 4, Jail B still have active cases. Next. Let me end my presentation with a reminder. In our pandemic response, no one should be left behind. Next. We would like to acknowledge the following. Maraming salamat po.
Thank you, Dr. Kashmira Maramang, for your nice presentation, and congratulations on your presentation. It's a very important study. So it's a containment area, so it's very likely to spread the transmission. So good work. So we have a couple of questions from Bina Rai. One question is, how many inmates roughly in each jail?
In each jail. Well, for Jail A, there are about 3,000 prisoners or PDL. In Jail B, around 26,000, and Jail C, 2,000 or 3,000.
Okay, so there are a couple of questions. I think these are common. Like one question is there any changes taken by the jail authority to improve the living condition in the jail? And similar questions like how are the jail compliance with this recommendation? So can you please answer this question?
Okay. For the living condition, they are planning to expand the jails, but this is a long-term plan. And then for what's the other question?
The other question is, so is there any changes taken by the jail authority to improve the living condition in the jail?
Okay, since physical distancing is hard to maintain, so they distributed face mask and soaps so that they can practice hand hygiene, and so that they can control at least slow down the transmission of COVID-19. And there's also the law on good conduct and good conduct time allowance. So they actually prioritized the ill and the elderly who have had showed good conduct to be released to decongest the jails.
So one question is, what is the outcome of this recommendation? So is the current case number in days jails reduced?
Yes, as you can see on my slide, 25 cases reduced since August, and we have seen a decreasing trend. So Jail C reported their last case in June, while Jail B reported their last case in first week of October.
Okay, thank you. So we have a couple of more questions, but we are running out of time. So I will take some of the questions. So one of the question is, was the factors with significant odds adjusted for any possible confounders?
We use the stepwise multiple logistic regression to control for the confounders. So that's out of the 19 associated factors known to COVID, we reduced it to six factors.
Okay. The question is, it seems like the outbreak took a few months. Do you have any explanation why it took so long time? From Wana Hanswarakul.
Okay, if I take you back to that time, our case definition for disease detection on that time is those who have travel history, and because jails are a closed setting, we are not really expecting that the outbreak will happen. So and traditionally our disease surveillance reporting units are health facilities or health offices or Center for Health and Development. So these jails are before they're not really reporting their number of diseases or seen in their jails. So that's why the guidelines now, as seen in our slide 23, it was revised that the mandatory reporting included jails and prisons.
One more questions from Taiwan FETP, Angela Huang. Did you see other outbreaks in jails? So there are.
Yes, after.
Yeah, please go on.
Yes, after this investigation, another fellow of mine studied the jails in another region, and there are other reported jails also with clustering.
Okay, another question from Angela. So it's sort of my question thing also this, because your conclusion was the rapid spread of infection was due to high congestion, and I was wondering that do you think any sort of recommendation to reduce the congestion of the jail? So do you want to recommend anything? So the question is like that way, that it looks like that you have identified sharing meals as a risk factor. Was there anything that could be done to prevent disease spread through sharing together?
The PDL were advised to limit their congregation because they were accustomed to share meals with their gang mates. So due to COVID, they were reminded and educated about how this disease spreads. So they were advised to at least limit their sharing of meals. And actually, it was also in the guidelines that we recommended the staggering of mealtime so that they will not congregate. Different cells will not congregate while eating. And that's it.
Okay. So thank you, Dr. Kashmira Malamang, for your nice presentation. I think a round of applause for all the presenters from me and from the team that for your nice presentations. I would like to congratulate all the presenters and the enthusiastic participation of the audience during the discussion session. Thank you so much. I would like to thank our organizer, the FETP Taiwan, and the whole organizer for successfully organizing this conference. And with this, I would like to conclude our presentation session. And I would like to hand over my microphone to Dr. Wan Chin Chen for further process. Thank you all.
Thank you, Dr. Roberni, and thank you all presenters today. So we are going to close our today's session. So see you next day. See you tomorrow at the same time. Thank you.